इसमें कैमरा ऑन करने की जरूरत है? बता दीजिए करना है। मैं इधर से भी कैमरा ऑन कर देता हूँ, मेरे को लेक्चर देखना है। हेलो
he was at To Record Csp police statement at our place. बर्थडे को तो पता नहीं पड़ता। चलाने वाला है? पता नहीं, मेरे को तो लगा था I was expecting कि कोई आएगा इस बार। शामिल नहीं। कितने की आती है मार्केट? It is around, मतलब if you take a advanced version which is more for physiology, is around 45. आप लोगों के 45 लाख? Because you know, for a physiologist, this is a very new upcoming technique and really good. All clinical departments you can collaborate on physiology and research.
Good morning, Ajay. Is my slides visible from your end?
हेलो वो स्लाइड
अभी हाफ ही है.
Good morning, Ajay. This is Kaviraja. My slides are.
अभी इसमें शेयर हो रहा है. हेलो. मैं दोबारा शेयर करता हूँ.
बोलेंगे जो बात करेंगे तो चल जाएगा.
इसका माइक बंद नहीं है. मैंने म्यूट किया हुआ है. म्यूट है ना. एक ही माइक ऑन करेंगे बस. इसकी तो जरूरत नहीं है ना. माइक और रिकॉर्डिंग उससे हो जाएगी ना. ऐसा कुछ तो नहीं है कि इसके माइक और स्पीकर की जरूरत तो नहीं है ना. फिर उसी से करेंगे. बाकी यहाँ मैं एडमिट करना होगा तो यहाँ से करेंगे.
चला रहे हो वही जो आपको चला रहे हैं. ट्रैक पर आपको वही चीज कंप्लेंट नहीं कर पाते. खुश हो जाते हैं.
समझिए तो एक बात अगर वो दूसरे लैपटॉप पे प्रेजेंट कर रहे हैं ना, वो अपने वाले लैपटॉप से ही बोलना चाह रहे हैं. इससे म्यूट रखना चाह रहे हैं. तो रिकॉर्डिंग होगी आवाज से.
उसके बाद 70 गुवाहाटी राजकोट
उसमें पावर वो तो सिर्फ पावर पॉइंट ही आ रहा है. हेलो हेलो.
स्लाइड डिस्प्ले हो रही है. स्लाइड पे डिस्प्ले हुई क्या?
एक मिनट बताओ.
फर्स्ट तो स्लाइड पे
अब वो जो भी आप डिस्प्ले करेंगे
थोड़ा दूर आ गया. अलग बात.
तो अगर इन केस प्रेजेंट को अपना फेस दिखाना हो तो प्रेजेंट करें. कैमरे को मैं शिफ्ट कर दूँ फिर वहाँ पे कि जरूरी नहीं है फेस दिखाना. तो मेन चीज़ तो प्रेजेंटेशन है ना. ठीक है. नहीं अगर दिखाना होगा तो नहीं ऐसा कुछ दिखाना होगा तो थोड़ा बहुत कैमरा मैं ऑन कर लेंगे. फिर करेंगे. बस इस पे तो नहीं करना कुछ नहीं. उसका ऑडियो खुला हुआ है. चल रहा है. अब हम इसे डिस्टर्ब नहीं करेंगे।
Good morning, everyone. Welcome to this workshop on transcranial magnetic stimulation. Before we start with today's program, I would like to request all of you to please share your DMC or State Council registration number on the chat. This is required, I think, for getting your credit points or giving you the credit points. This is required by the Epicon organizing committee. Please share your registration number on the chat. And I think we have few other guests also online. If they can also, so I think we have Dr. Prabal Joshi with us. Good morning, Dr. Prabal. How are you doing?
Yeah,
Can
good morning. Good morning, ma'am.
Cameras on also?
Sorry,
If it is
sorry, ma'am.
possible?
Sorry. Can you repeat, ma'am? Can you hear me? Can you hear me, ma'am? Am I audible? Hello. Am I audible?
Good morning, Dr. Prabal. Are you saying something?
Hello. Good morning.
Hello, Dr. Prabal. Good morning. We have Dr. Suvankar also here online. Can we have please your cameras? Dr. Kaviraj, you can also have your camera on. So we have Dr. Kaviraj with us. He is professor at Department of Neurophysiology, NIMHANS, Bangalore. Good morning.
Good morning, Dr. Suman. How are you?
Fine, thank you. Great Prabal, Dr. Suvankar, Dr. Jayakumari, Dr. Hindera. And then we also have Dr. Ankita Sharma. Dr. Ankita, you are from which place? If you can please share your details. Dr. Ankita
कौन हम कितों
and Dr. Kochhar are also there. Dr. Ankita, we can't hear you. Good morning, Dr. Divya.
Good morning.
So you will also be joining online. I thought we were expecting you
No,
to see
actually,
here a team.
I'm stuck in the traffic, and it is. Yeah. Actually, I'm stuck in the traffic. I'm still driving, so I've joined online till I reach. I'll be reaching, I think, in.
Okay, that's nice. Yes, of course, of
Yeah,
course.
yeah.
Thank you.
There's a lot of
So
traffic
see you
congestion
soon.
here, so I'm stuck. Yeah.
Okay, okay. You're coming for which place? From where do you stay?
I'm coming from Agra right now. I'm from SN Medical College, Agra.
Oh, Ajay, you must be finding a lot of traffic there.
Yeah.
So I think we can start we can start the program. So we also have a few delegates present physically in the seminar room of Department of Physiology. So can we have camera on them also? इसको कैमरे को उनके उस पे कर सकते हैं क्या? या मैं इसको हिलाऊं तो थोड़ा सा हो जाएगा. So if you can introduce yourself.
I am Dr. Gaurav Sharma and I am assistant professor at AIIMS.
Welcome, Dr. Gaurav. So Dr. Gaurav is from AIIMS Rajkot, and Dr.
My name is Dr. Varun Malhotra and I am serving at AIIMS Kochhar.
Yeah, welcome. And
Dr. Abhinav Dixit, professor at AIIMS.
welcome, Dr. Abhinav. Abhinav, please come in front. So, welcome to all of you and welcome to all the delegates who are present online and attending this program or attending this workshop. So, I'll start sharing my screen. So the program will be that I'll be talking about basic principles and physiology of TMS, and Dr. Kochhar will be soon joining with and welcoming formally to all of you. Then we have a lecture by Dr. Kaviraja. He's professor, as I said, Department of Neurophysiology, NIMHANS, Bangalore. Followed by a small, maybe a tea break. We'll see when the tea is available, at least physically, with presentations of the entire setup, entire procedure. And physical, then we'll move to Brain Stimulation Lab and we'll show you all the procedure. Okay.
So I'll start with basic principles. So first of all, what is TMS or what is transcranial?
कोई बात नहीं, अगर नहीं आ रहा तो I'll start with basic principles. Stimulation
Techniques now being used by various clinicians like transcutaneous electrical stimulation, deep brain stimulation, and number of others.
So it's a non-invasive method of brain stimulation techniques. As we all know, there are a number of brain stimulation techniques now being used by various clinicians like transcutaneous electrical, which is actually non-invasive, and that is why it has so much. And now so many people, everybody, clinicians, scientists, everybody is talking about TMS. And obviously it doesn't require any electrodes. You just put on the scalp and then you provide the no pain associated with this, because if you think of transcranial electrical stimulation, then you're putting electrodes on your scalp, and once you're electro putting and therefore that could be very painful. Whereas in this case, since coil is just put on the scalp and then magnetic fields are generated, so it is nearly very minimally, or actually there is no muscle spasm, no pain associated with it. Okay, and this is actually a very quite recent technique, because it was in 1985 that Anthony Barker actually introduced the term TMS, and at that time actually he was using this technique actually for quite some in our institute also, when I think Dr. Madhuri Bihari, neurologist, she purchased the first TMS that was more for recording motor evoked potential, measuring the conduction velocities and so forth. For therapeutic purposes, actually, it took very long to come up. Okay. And so Pascal Leon then in 1990 used the word of RTMS, as we know, multiple sessions.
Share नहीं हो.
So and he used Pascal Leon actually. That is how it started. So what is the principle? So principle is basically, all of us know, we used to read in physics electromagnetic induction. Everybody knows about it, that if you keep an iron bar near a coil and if you pass the current in a coil, then iron bar is getting magnetized. Okay, so when there is a current is passed through a coil, so we basically talking of a coil through which this current is passed, and when current is passed, magnetic fields are induced. These are magnetic fields actually which can penetrate through the scalp, and these they pass through the skull without any interferences. And again, when these are changing magnetic fields, and then they can induce electrical or eddy currents, as we say, in the brain tissue, and therefore altering the membrane properties of neurons or different type of cells which are present there. Okay, so that is basically the concept. So it is based on electromagnetic induction, that electric current is passed. So that is what is given by Faraday. So magnetic field can be generated by running a electric current through a wire coil. Conversely, a changing magnetic field can generate electric voltage. And how much voltage will be loop and rate of change of magnetic field. Okay, so so that is what it is. So electric currents which are produced, they will alter the properties of these neurons which are present in the brain. Okay. However, the limitation could be that when you're using this type of coil, they're not able to stimulate the deep structures directly. Okay, because the penetration is around 2.5, can go to 4 centimeter, but not beyond that. And therefore, if you have to stimulate other structures, maybe thymus or striatum or other structures, then most of the time it is through. So if you are talking of Parkinson's disease and saying that, okay, basal, I think that's what Dr. Kaviraja will also tell you, then it is more through the cortex than it is getting stimulated. Okay. Now, what as a physiologist also we have to understand that neurons are not arranged. All the neurons do not have the same orientation when they are present in the brain. So some could be say perpendicular range to the surface, some could be some 40 different angles, and some could be parallel to the surface. Okay, and therefore the current which will be induced will be decided by the angle which is being formed between the orientation of the neurons and the coil which is placed on the scalp, right? And this angle, as was given by Fox, is cosine angle. Okay, so this is a cosine angle, and therefore if you consider these neurons which are parallel to the surface, the cos 0 will be 1. Okay, and so maximum current will be induced in the neurons which are arranged parallelly, and then perpendicular means cosine 90 or cos 90 is 0. So least will be in the neurons which are arranged perpendicularly, and in between, whatever the angle will be, the amount of current will be introduced. So therefore the different neurons which may be arranged in different orientations will have different their membrane properties will be altered differently. Okay. Now other thing is that when you are using TMS, okay, so this is, say, a pyramidal neuron, motor neuron, which is present in the cortex. So this is a pyramidal neuron. So if you are putting an electrode, so if you are doing transcranial electrical stimulation, then since the surface area which is covered by an electrode couldn't be very small, and therefore there is a possibility that you can directly stimulate one or two the pyramidal neurons directly. Whereas in case of TMS, even if you're using most recent coils, most of the times it is the transsynaptic activation of these neurons are activated transsynaptically, and therefore if the recordings is done from the corticospinal tracts, we get indirect waves, as we call it, I waves. And then if you're doing transcranial electrical stimulation, then it is more of D waves. Okay, so these are indirect waves which are being generated in response to TMS. Okay. So there are different type of coils which are available in the market, and depending upon what you are interested in, you can use different coils. So this is a figure of 8 coil which is more commonly and more routinely being used. Okay, this is a double cone coil. It has a specific angle, and because it is angulated, and therefore it has a property that it can stimulate slightly deeper structures, and therefore in our lab we are using to stimulate the leg area, which is actually present. If you look at the homunculus, then it is going into the central sulcus, and therefore to stimulate the leg area, then we are using this double cone coil. Then there is a rat coil also, which is in case you want to conduct some animal studies. So now we have in the market rat coils. So this coil is again available in our lab at AIIMS Delhi, Brain Stimulation Lab. And this is the coil which I was talking about, that H coil is the recent advancement. And they say, okay, it can go to 6 to 7 centimeter or more than 5 centimeter. But practically, definitely it will be more slightly less. But definitely you can achieve some deeper levels using this type of helmet type of coil, which is known as Hazel coil or H coil. Now, TMS, through this equipment, you can deliver different type of pulses, and therefore different paradigms can be designed. Most commonly is used is single pulse TMS, because you are giving single pulse at a time, and therefore if you're giving one pulse to the motor cortex, you will get one motor evoked potential you can record. Okay, so that is single pulse. Then paired pulse paradigms, when you're giving pairing of the two pulse, I'll just come to them. And then RTMS, if you are delivering the pulses repeatedly, then we call it as RTMS. Okay, so mostly the single pulse and paired pulse are more used to explore or understand the cortical neural circuitry, excitability and plasticity. And RTMS is more used for therapeutic purposes, and therefore to induce LTP or LTT like conditions. So if you look at the applications of TMS, then we have number of them, and some of them we'll be talking about. So starting from cortical excitability, mapping, using lesions, conduction velocity, plasticity, and so on and so forth. Okay. Briefly tell about some of these things quickly, and then these all will be demonstrated after we are through with the lectures. So first, as I was talking, that initially we had this actually started with recording of motor threshold and motor evoked potential. So if you are stimulating the motor cortex, so you have a coil, you are stimulating the motor cortex, then you will get a recording of motor evoked potential. Okay, and this cortical signal period is actually a very important concept to understand the inhibitory circuitry. And in this, if you are giving a suprathreshold stimulus, then if you give a stimulus, then after the recording of the MEP, you get a silent period. Okay, so this is known as cortical silent period, okay, which generally lasts for 100 to 300 milliseconds, and this is due to GABA B type of neurons which are present in the cortex, and also at the spinal level, this could be due to refractoriness of the motor neurons or activation of the Renshaw cells. Okay, so this period has been shown to vary in different type of neurological conditions, and therefore this has a very important diagnostic value associated with it. Then you can also record conduction time and conduction velocity. So if you are, say, stimulating the motor cortex, then you will have motor evoked potential, then you stimulate at the spinal level, then you'll have another wave. You know how much is the distance, you know the latencies, and then for you can calculate the conduction velocities. Then you can also do some crude sort of brain mapping or the homunculus. Okay, so as we can see here, this is one of the manual method which we have been using in our lab. So you can make a grid on the scalp. Okay, 1 centimeter grid is made on the scalp, and then you keep moving your coil. So suppose you want to measure the hand area. Okay, so how the hand area is altered in, say, spinal cord injury patients, or maybe another cerebral palsy or any other condition, then what you do is you make a grid onto this, and then you go on stimulating and recording the evoked potentials. So at some point of time when hand is over, you get motor potential. So that is how you can map all the directions, the hand area. So this is a slightly crude method.
Now moving on to paired pulse. Now in paired pulse, what we do is that we give a conditioning stimulus and a tense stimulus. Conditioning stimulus.
So now moving
We are giving a subthreshold stimulus.
on to paired pulse. Now in paired pulse, what we do is that we give conditioning stimulus.
Stimulus is given before the suprathreshold test stimulus.
So if the interval between the conditioning and test stimulus is only 1 to 6 milliseconds, then what we recording is, and obviously we're recording the motor evoked potential, then motor evoked potential will be inhibited. Okay, so the amplitude of the motor evoked potential will be inhibited, and this is known as short interval intracortical inhibition. And this is due to mediated by GABA A type of receptors and neurons. And if if the stimulus interval between the conditioning and test is 50 to 200 milliseconds, again it is inhibited, but the receptors now involved are GABA B type of receptors. Okay, and this is known as LISI, or long intracortical inhibitory period. Now, if the interstimulus interval is around 8 to 30 milliseconds, that means more than 1 to 6, but 8 to 30 milliseconds, then we get facilitation. Okay, and this is due to NMDA type of receptors. And then you can also test the non-NMDA type of receptors, in which case you give the test stimulus first, followed by the conditioning stimulus. Okay, so this is the diagram which shows that you are giving two stimulus at the same point. So you are not giving stimuli at different areas, but the same area is stimulated first by a conditioning stimulus like this, and then by a test stimulus, and then you're recording, since the test stimulus is suprathreshold, so you get a motor evoked potential. So if the interval is 1, if it is 50 to 200, again there is an inhibition. Okay, this is due to GABA A type of receptor, GABA B type of receptors. If the stimulus interval is 10 to 15, then there is a facilitation. You can see the amplitude has increased. And if test stimulus is followed by conditioning, then also there is a facilitation. And this is due to NMDA type of receptors. This is non-NMDA type of receptors. So therefore, what you can see as a physiologist, you can understand that this type of paradigms is very, very important, in which case non-invasively you are able to understand not only crudely the inhibitor excitatory circuit, but also that which type of receptors are involved, which type of inhibitor receptors are involved. This is GABA A or GABA B, or NMDA or non-NMDA. Okay, so therefore especially this paired pulse paradigm is very, very important, and which give lot of information and has been used as diagnostic or prognostic markers for various disorders. Okay. Then coming to RTMS, I said RTMS, in this RTMS, you are giving pulses repeatedly at a specific frequencies, and it can be given with varying duration or interstimulus intervals. Now, purpose of giving RTMS, and as I said, this is more used for therapeutic purposes, that it alters the cortical plasticity, in the sense that if you are giving, it can result in LTP or LTD. Okay. Now, if you are giving low frequency RTMS, okay, 1 hertz, then there is a decrease in synaptic efficacy due to LTD. Okay, if you are giving high frequency RTMS, that is more than 5 hertz, that there is an increase in synaptic strength due to generation of LTP. Okay, so that is why in some conditions, say in schizophrenia or some psychiatric disorders, they give low frequency because you have to reduce the excitability. Okay, and that is then repeatedly so that LTD is there. Whereas in other conditions, which is more inhibitory, maybe like Parkinson's disease, you can give high frequencies. Okay, so that it results in LTP type of situation and increasing the synaptic strength. So depending upon what is the physiology or what is the morphology of the brain in that in the neurological disorder or psychiatric disorder, you can give different type of frequencies. Okay, and mechanism, I'm not going, we all know about the mechanisms of LTP and LTD. However, having said that, before I close up, it is very important that to understand that it is not so simple. There are not lot of other factors which are determining the outcomes of TMS, that is size and shape of coil. Okay, so like initially I said, whether it is a figure of 8 coil, whether it is a circular coil, or which double cone coil. So if you have started your intervention or your recordings using a specific, say a figure of 8 coil, then it is recommended that you use the same coil throughout the study. Do not change the coil in between. Change at least the shape or size of the coil, because that may alter your outcomes. Okay. Then what is the orientation of the coil? How you have placed on the brain? Have you placed it 90 degree or 45 degree? And what is the direction of the coil? Okay. How much is the depth of the brain area? What is your state of target area, whether it is at rest or actively? So whether you are asking the patient to do some mental calculations or something, then since we are altering the membrane properties, so if brain is already active, then the outcomes definitely will be altered. Okay. Then what is the intensity and frequency, which I just said? How many trials and how many sessions? So for psychiatric disorders, still we have, since initially it started more with the psychiatric disorders, we have standard protocols for psychiatric disorders. But for neurological disorders or neurodevelopmental disorders or neurotraumatic disorders, it is still under clinical trials, and clinicians and scientists are being trying to standardize the protocols, that how many trials should be given in one day and then how many sessions should be given. So they're trying to optimize these different protocols and how many trains and interval. Okay, I think I'll just go through the shape of the coil. Is passed in such a way that the magnetic fields which are generated, they generally activate a very small area which is just lying underneath the this where the two coils are joining. So the area which is stimulated is quite less, where in circular area, the area which is getting stimulated is quite large and more on the peripheral side, on the rim rather than at the center. Okay, so that is why the shape of the coil can affect. Frequencies, like I said, okay, low frequency is inhibitory and high frequency is stimulatory, which I have already talked about. And then stimulation depth. Okay, so it has been seen that as we go down, so if the coil is present at the top, as we go down, the intensity, the strength of stimulation decreases. So most of the coils, they are able to stimulate figure of 8 coil as we are using to maximally to 2.5 or 3 centimeter maximum. Okay, so that is the stimulation depth we talked about. Okay. So in the Brain Stimulation Lab at the Department of Physiology, so we have our research group is working on both human patients, subjects, as well as animal models of neurotraumatic like spinal cord injury, neurodevelopmental like cerebral palsy, autism and other disorders, as well as neurodegenerative, Parkinson's, Alzheimer's, and maybe we'll start with ALS and other. So that is what about the basic principles. Thank you to all of you. And I think what can be done is we'll have Dr. Kaviraj lecture in between. And Dr. Kochhar is here. So before I invite Dr. Kaviraj, I request Dr. Kochhar to please welcome the delegates formally and say a few words.
Good morning, Dr. Suman. I mean, Professor Jain, and a very warm welcome to all the delegates, offline and online. It is my very pleasant duty to introduce the main organizing person, main organizing chairperson, I should say, not even organizing secretary of this workshop. And she has had an experience of, I think, about 30 years now in working in the field of neurophysiology, and she on her shoulder harbors a great legacy from Dr. Bikyanand, whose student was Professor Usha Nair, and she was a direct student of Dr. Usha Nair, and she's an alumna of AIIMS right from her graduation, BSc Honors with merit in human biology, followed by MSc in physiology under Professor Nair, and then followed a PhD, and then she has had special trainings, and like a model clinician scientist, I would say, there are no boundaries whether we are coming from the MSc stream or the MBBS stream. We have examples, Professor Ratna Sharma and Professor Suman Jain, who are coming from the MSc PhD stream but have a lot of MBBS and MD people working under them. So I feel that when we are talking of translational neuroscience, her laboratory harbors a great legacy of neuroplasticity experiments also, as well as she has been instrumental in making from scratch the RTMS setup, both for animals and humans, the spinal cord injury model, whether it is a concussion model, whether it is a incomplete transaction or a complete transaction model, and also the Parkinson's disease model, Alzheimer's disease model, as well as we also have, the lab has a legacy of making from Dr. Anand's times, having models of hypothalamic lesions where we can have the starving rat who is not feeding at all and the obese rat who is feeding all the time. And now Madam plans to extend the neural part to the metabolic part, because we all know there is a neuroendocrine and a neuroimmune metabolic axis also. So then she has pioneered, she is a founder member of the Indian Society of Nanomedicine, and she has set up very pioneering experiments, about 5 or 6 PhD students who has worked not only the magnetic field, okay, the field exposure, to making iron superoxide nanoparticles, and to give very, very targeted delivery of changing the magnetic field and how it is healing. I work in some areas of traditional lifestyle and traditional light, and we know that from thousands of years ago, we were prescribed to wear some kind of a bracelet of certain ferromagnetic substances, or having water from certain proper metals which have a magnetic outcome. So we are now taking these things into an evidence-based medicine, and she has a great lab and great resource persons, very bright young ladies and gentlemen who are working, and we wish you all success in your learning. Please free to interact, visit the lab. If you are online, you can visit anytime, and I wish all success to the workshop.
Thank you, ma'am. So it's my pleasant duty now to invite Dr. Kaviraj. Dr. Kaviraj has a vast experience of working in transcranial magnetic. I feel like whenever I go to Bangalore, I make an appointment with him, visit his lab, and all the techniques which I'll be actually sharing with you and teaching is being taught by Dr. Kaviraj. So that way he's my mentor, and I request Dr. Kaviraj to please share his expertise that how TMS can be used for clinical physiology, which is actually now the most, everybody is talking of clinical physiology, and we would like to contribute to this. So
Thank you,
how
madam.
this
Thank
TMS
you.
can be used for clinical physiology. Over to Dr. Kaviraj.
Thank you, Dr. Suman and Professor Kochhar, for your kind cooperation and support during this workshop. I'm always a student in physiology, and I would like to learn all the times. So I'll share whatever the information I have, and we can always discuss more. So during my lecture, is my slides moving? Yes. So Dr. Suman has made my job very easy by talking on the basics of all different types of non-invasive brain stimulation. I'll just briefly go through that, and some of the studies in which we can understand the brain circuits by using single and paired pulses, and also with the combined RTMS and TDCS studies, in which we can modulate the plasticity and change the neuronal circuits, and that's how we can use it in various neurological and psychiatric disorders. I'll give a brief glimpse of some of the studies being done at our lab. Some of these ongoing studies and some of the future directions. And as a physiologist, we should always explore how we can use this tool as a tool to understand the brain circuits as well as help patients. So that's how the translational or clinical physiology is very important. And since physiology is the mother of all the medical subjects, we should be contributing more on to providing this information, especially to busy clinicians who will be very much willing to give their patients for understanding the brain circuits in terms of clinical investigation, or use it as a therapeutic modality. So these things we should always keep exploring, then only the physiology field or can grow further. So some of these things Madam has already told. So this is a brief overview of the various non-invasive brain stimulation techniques. So mainly two modes of stimulation, either magnetic or electrical. In electrical, we have TDCS, TACS, TRMS, that is the random nerve stimulation, and various nerves can be stimulated in terms of vagal nerve stimulation or galvanic stimulations of vestibular stimulation. So these are different types of electrical stimulation. Of course, today's topic we will be talking only on the magnetic stimulation. So also there are other modes like ultrasound. Transcranial ultrasound is getting lots of importance, and we also have a project in which we are exploring the utility of this in various mood disorders, transcranial ultrasound. This is in research in progress. Of course, the single and the paired pulse to explore the neuronal circuits, we will be talking some of these measures in various neurological and psychiatric disorders. And repetitive transcranial magnetic stimulation, RTMS, as Madam has told, the low frequency has an inhibitory things because it produces LTD, long-term depression-like effects, whereas high frequency RTMS induces the excitation by LTP-like mechanisms, and we have different patterned stimulation, continuous 8-hour stimulation. Again, continuous is inhibitory and intermittent is excitatory. If possible, we will show some of these protocols. So whole idea is to explore the brain. So the brain functions, the neurophysiology can be studied both various mechanisms, various modes. When we have these different modalities, always the spatial and temporal issues will be there. So here the spatial refers to how best we can understand the functions in terms of neuronal level or the circuit level or more of a gross level. So as the graph in the x-axis, it goes more towards more away from the zero. That means we are compromising with the spatial resolution, and similarly temporal resolution is shown in y-axis. So in terms of changes that's happening, say when you give some stimulus, what exactly happens to that particular part of the brain, it would change temporally in milliseconds, seconds, minutes, hours, or days. So whatever we are doing, say in terms of drug manipulation, it has lots of spatial as well as the temporal resolution issues. The effects may be seen after a few days, or it might be a gross effects seen in various aspects of the brain. So we won't be able to pinpoint where exactly the changes happen compared to that of the optogenetics, where we have a very good temporal as well as the spatial resolution. But of course, we can use it only in animal models in microscale levels to pinpoint exactly what's happening in that neuronal levels. Even microstimulation is there. We can do it in patients undergoing neurological surgeries like epilepsy surgery or deep brain stimulation surgeries. Whereas all these non-invasive modes of electrical or magnetic stimulation has some sort of temporal as well as the spatial resolution issue. In terms of spatially, we can't pinpoint into a specific group of neurons. It is once we are stimulating the motor cortex, it is somewhat a gross level of stimulation, in which again we can use a specific coils, figure of 8 coil or butt shape coils we can use to get more spatial resolution. However, there is some challenges there, but temporally we have a very good in terms of getting single pulse studies. We can even get within few milliseconds the effects, and whereas RTMS has long-lasting effects to minutes to hours or something like that. So these things we need to always keep in mind while doing TMS. It's having some amount of spatial resolution issue. Temporarily, it's still better compared to that of the lesion or drug manipulation studies. So Madam has made my job easier by showing all these mechanisms, different types of coils. Circular coil has a diffuse area of stimulation, whereas figure of 8 coil has a very peak magnetic field generated between those two circles. The point between two circles, and the midpoint of the 8 has the maximal amount of magnetic field generated. So when we use this coil, around 2 to 2.5 centimeter below that coil area is the maximal stimulation generated. That roughly corresponds to around layer 2 and 3 of the motor cortex when we are stimulating the motor cortex. This also Madam has shown. So when we are stimulating, it is different layers. That layer 2 and 3 is getting stimulated. There also we have both inhibitory and facilitatory circuits, which in turn feed into the pyramidal layer, the layer 5 in the motor cortex, and from there the corticospinal tract at the spinal level and the motor neuron innervating the hand muscles. Usually we take the hand as the target because, as Madam has shown, the homunculus we have larger representation for the hand area. Of course, we can use the facial muscles also, but hand area is physiologically the target, and that too the first dorsal interosseous muscle. Sometimes the thumb muscles can also be used as a target. It's easy to get a very defined peak of motor evoked potential. So as I told, the layer 2 and 3 are getting stimulated when we stimulate the motor cortex, in turn activate the pyramidal layers, and that the corticospinal tract get activated, and we get a response in terms of motor evoked potential. The peak-to-peak amplitude, what we generally take as the MEP amplitude. The latency is from the stimulus artifact. This is the first line, is the stimulus artifact, the time in which we stimulated the motor cortex. It takes around 20 to 25 milliseconds depending on the height of the individual and his integrity of the particulospinal tract. Sometimes with the multiple sclerosis and other demyelinating disorders, this the length may be altered. That's also one of the measure to study the neurological disorders. So homunculus madam has already shown. So we have a larger representation for the hand and the facial muscles, and the initial homunculus was defined by Montreal neurosurgeon Penfield by doing the epileptic surgeries. Now we can do that with the MRI of the patient. We can clearly tag which is the area for that particular the hand or the various other the upper limb muscles as well as the lower limb muscles would be between these two hemispheres. So we have to use the circular coil usually to target these leg muscles. So this is our lab in the Department of Neurology, the TMS lab. This is my PhD student, and we can also use this neuro navigation tools to pinpoint exactly where we are going to target which area of the muscle, which area of the motor cortex, so that we can target the specific muscles, the first dorsal interosseous or the thumb muscles. This is the paired pulse TMS device. We can use two stimulators to get the paired pulse. I will show you some of these things. The RTMS we have there. So the other in the afternoon or the later on workshop, we will be showing individual these things. Briefly discuss the motor threshold is the minimal intensity that we can use to get a defined MEP amplitude. The resting state we define it as 50 microvolts on the active state. In the active state, person is actively contracting. You can see some background AMG. Then the threshold would be, because the motor activity is there in the particulospinal tract already. The resting compared to the resting motor threshold, active motor threshold is slightly low. So the definition will also change because the background EMG is already there. So it is 200 microvolts for the minimal intensity to generate 200 microvolts of 5 out of 10 stimuli. We take half of the time because sometimes, as madam has told, various factors are there in MEP generation. Mainly depends on the type of the coil or the place which we have kept the coil, the orientation of the coil, and also in terms of subject specification, how awake the person is. If the person is feeling drowsy, we may have to increase the intensity to generate a known MEP amplitude. Recruitment curve is as we increase the intensity of stimulation, the MEP amplitude will also increase, and we get this is kind of input-output curve, and the slope of this curve represents the excitability of the particular neuromuscular activity of that particular muscle. For hand muscles, it is more steeper compared to that of the proximal muscles, the shoulder or the neck muscles. It is more you get saturated. So basically, based on the size principle, as we increase the intensity, more and more neurons having the lesser excitability also in the motor neuronal pool gets activated, and that's how we will be able. But it will get saturated around 150% of RMT. This is one thing we can demonstrate also. It's easy to record. Basically, it is not a silent period. So it is the length of the electrical silence when the person is actively contracting. The person is here actively contracting, and you can see this is the background EMG. Then there will be an stimulus artifact because of the TMS stimulation. Then the MEP generated. We are not interested in any of these things. Following MEP, there is a pause in the electrical activity of that particular muscle. EMG is nothing but the electrical activity of muscle. So there is a pause. That pause is because of mainly a GABA B mediated circuits both in the spinal or the cortical level. How exactly they know? they have given GABA B agonist and antagonist, and they have seen change in this length of the silent period. Usually it is around 100 to 120 to 130 milliseconds. So you can see here an example of Parkinson's disease. As you know, Parkinson's disease affects one side more than the other. So it is the more affected side, and the person is off medication. That is more pathological state. So the silent period is around 50 milliseconds compared to that of the on state in the less affected state. It's more physiological. So it's around 120 to 130 millisecond. So you can use silent period as a prognostic measure as to how much is the pathology in that particular the brain area. We can get and this one. We can also use it as a measure of how much is the dopaminergic medications alters the silent period, as to get there is a correlation of how much is the dopaminergic response to that of the silent period also. And we have also used silent period in some of the interventions like yoga interventions. If you give, then there will be increase in the GABAergic inhibition as shown by the silent period. So we can use this measure as a prognostic as well as an investigative measure. The center motor conduction time is when we stimulate the motor cortex, we get a response. When we stimulate the spinal level, we can do it even in the lower part of the axis, even at the ulnar level, we can stimulate. We can stimulate here and we get a response. So we can use that to identify in that tract which where is the lesion. Say a tumor suppressing this corticospinal tract in the maybe thalamic or somewhere in the brain stem, there will be delay in the conduction. That we can use the center motor conduction time for that. Just like when we are doing nerve conduction studies, we stimulate the proximal and then we stimulate the distal. We measure the length of that thing, then we can deduce what is the velocity or what is the latency. So the homunculus things I have already discussed, and all these measures, the single pulse measures, we can use in various neurological or psychiatric conditions. And this is a table showing the motor threshold, center motor conduction time, silent period, MEP amplitude, and recruitment curve, or the mapping of the muscles of representation. Some of the conditions we need to explore further. Some of the conditions already known. It's affecting all these measures in various ways. So this is how we need to study in a given disorders and use these as a measure of investigations to understand the neuronal circuits in these disorders. Briefly, I will talk on the paired pulse measures. One of the measures classically we use is the short interval intracortical inhibition. So here a single pulse is given, we get a response to MEP, say 1 millivolt MEP. When two pulses are given, here exactly two pulses are there with a very short interstimulus interval of 2 milliseconds. So then the response that we are going to get gets decreased. You can see compared to that of the test alone, there is more than 50% reduction. And if the interstimulus interval is say 10 milliseconds, there is facilitation. So why there is inhibition in 2 milliseconds? It is the GABA A mediated inhibition is there. How exactly you know this GABA A? We can give GABA agonist and antagonist. Investigators in 90s and early part of this century, they have done these studies, and we know exactly this GABA A. And the ICF, the intracortical facilitation, is due to glutamatergic activation. So we know by giving a specific pharmacological intervention, we know it is these things. And again, it's shown here up to 5 milliseconds there is inhibition, and over that time after 7 milliseconds facilitation is seen. Why exactly is that? It is time specific. It depends on the GABA B mediated GABA A, B or glutamatergic. They take that time, the molecular mechanisms in which they open the channels and activates or either inhibit or facilitate the neuronal circuits by opening these ionic channels. So that's how those timings are important, and we can do further studies in rat models to understand more on this molecular mechanisms. So again, when we are talking about when we are talking about one pyramidal neurons, it is getting innervated by thousands of interneurons in the layer 2 and 3, and there are few are facilitatory, few are inhibitory. Here, silent period, which is GABA B mediated, Aliya long interval cortical inhibition is again GABA B mediated, SICA is GABA A mediated. These are all inhibited neurons. There are also some facilitatory neurons are also there. So it's in terms of these neurons, there will be activation of either facilitatory or inhibitory neurons, and that's how we can study more with the animal model studies. Sorry for that interruption. I had an urgent call from that. So these things we can study by various excitatory or inhibitory parameters. Some of these things will be shown later in the workshop. So there are various facilitatory parameters, inhibitory parameters. So in a brain, it is the balance between these inhibition and the excitation circuits. That's how that balance, samatvam, what we call samatvam yoga uchate. We need to have a balance. That balance will be there. The homeostasis or interior will be there in healthy condition, but that balance gets altered in some of the pathological conditions. So in some of the conditions, the inhibitory circuits will be more, say in depression, one classical example. And excitation will be more in conditions of auditory hallucinations in schizophrenia. They are getting hyper excited in that particular auditory areas. That's how they hear various voices which are not there for a healthy person. So that's how we need to, this balance gets altered. That's again, we can fix it using these stimulation modalities. In depression, we can give high frequency AIIMS to increase the activity in that dorsolateral prefrontal cortex, or in auditory hallucinations, we can give inhibitory 1 Hz EMS, AIIMS to inhibit that area in the auditory cortex. That's how we can use these. This again a visit table showing various period pulse studies in various disorders. Of course, some disorders has already been established. Some of the disorders is not yet studied. So we can pick up any of those areas which has not been studied, and we can work on it further and get a pathophysiology of that particular disorder, be it bipolar, schizophrenia, or any of the disorders you can think of. We are also working on patients with attention deficit hyperactive disorders and addiction modalities. These are ADHD in their adolescent or the childhood, and then develop into addiction in their adulthood. So we are seeing, of course, it's a study in progress, and we are seeing some interesting data, especially in Aliya. There is a lack of inhibition in Aliya. Briefly talk on plasticity. Madam has told the LTP-like and LTD-like measures. The high frequency AIIMS is LTP-like, so we can use it in, say, in dorsolateral prefrontal cortex stimulation of high frequency AIIMS in depression, whereas low frequency AIIMS can be used on auditory hallucinations in schizophrenia. Like that, theta burst stimulation is there, continuous is inhibitory, intermittent is facilitatory. Paired association stimulation, we can stimulate the median nerve, which sends impulses to the motor cortex to the N20, and then plus 3 milliseconds the sensory motor crosstalk, and then that time 25 milliseconds we can stimulate, and that repeatedly when we are doing just like a spike time independent plasticity, there will be generation of plasticity. TDCS also we can use. So there are various molecular mechanisms to show this LTP or LTD-like mechanisms. Again, they have done pharmacological studies to interpret these things. We can do pharmacological intervention along with these activation of either inhibition or facilitation to get to know about that. Madam has told various factors which affect that, including age, gender, the neuroanatomy, the time of the day, person's brain state, whether he's awake, fully awake, or drowsy, or sleeping stage, and all those things we can use various mechanisms pharmacologically, physiologically, or even neuroimaging studies can also be used. RTMS in therapy, it's approved in depression and all the other conditions. It's being explored. We are also exploring in tinnitus, epilepsy, and as I told, auditory hallucination, schizophrenia. In stroke, there are various models. Stroke, when it's affected one side, it is the opposite side gets hyperactive. That can be either used as a constraint-induced immobilization on the healthy side can be done, or we can use low-frequency RTMS on the healthy side to decrease the activity in that thing to reduce the inhibition and the interhemispheric inhibition from the affected to the unaffected side. So various movement disorders also we have tried to use it in Parkinson's disease, dystonia, and myoclonus, but the effect size is not that great compared to, because mainly, as Madam has told, these are the affected regions in all these movement disorder is subcortical structures. So when we stimulate the cortex, it won't have much effects because it's the effects are secondary. The primary effects in the basal ganglia circuits in all these movement disorders. So we also tried to combine TDCS and ITBS, one of the intermittent theta bud stimulation, as a mode of therapy. And it's ongoing study. One patient's report has been published. And we also used, as I told, the corticospinal period can be used as a mode of GABAergic inhibition. So following yoga therapy, you can see a significant increase in the silent period compared to that of the waitlist control. Not much change in that. It was significant. Compared to other SICA and ICA, we didn't see much difference. Some of the future direction can use different modalities. Nowadays high density TDCS is coming. We can stimulate exactly area where is the anode is specifically put, and cathode. There are multiple cathodes can be kept, so that is only one particular area. Just like 128 or 256 channeled EEG, these kind of things are also coming in TDCS, which can be used for multi-channel stimulation in neuroelectrics. That's one of the study, one of the future direction. And also, we can use various modalities. Here, TMS have been used with various other imaging modalities like EEG or PET imaging, fMRI, NIRS, or MRS, magnetic resonance spectroscopy, or various non-invasive or invasive modalities we can use, and we can see the changes that's happening within the brain using pharmacological agents or physiological measures like EEG and MEG and other imaging measures. Then we can find out this causative and functional consequence of these, which is seen in with the excitatory and inhibitory imbalance. As I told, in various neurological condition or psychiatric condition, this balance is altered. That balance we can try to work it on towards the normalcy, and also we can do, as Madam's Professor Suman's lab, various miniature coils is used for the animal models. Even micro coils are also there. We can target specific, just like patch clamping techniques, we can use that microscopic stimulation, and we can use the slice preparations to alter the excitability in the specific areas. So just like optogenic modulation, we can activate these circuits in the rat brain. Similarly, when we stimulate, say, dorsal prefrontal cortex, the effects are also seen in the subcortical structure because it's a network level alteration, the nucleus accumbens, retrotegmental area of the various other regions getting altered because of these glutamatergic or dopaminergic projections. So that we can study with various imaging modalities. So nowadays, even patient-specific stimulation, whatever the changes happened, we can see the changes even by EEG, MEG, or other imaging modalities, and from that recording we can compute what is the specific modality. Say, as I give an example of depression or hallucinations. So depression, there is decreased activity in that specific area. So we can target that area to alter the neuronal activity, or in auditory hallucinations, we can use increased activity, we can use to target that particular area in that. So those are the newer directions we can think of, and of course, now in terms of ongoing studies, we've been using the TMS and combining the various modes, and also using these modalities in various disorders like REM sleep behavioral disorder, which is one of the precursors for Parkinsonian disorder. So REM sleep behavioral disorder is shown patients with RBD and NRBD. Specific differences we are seeing in ICF, intracortical facilitation, and also in SCAI, the short afferent inhibition, which is a cholinergic circuit. So these RBD patients tend to develop into more cognitive deficits. It's an ongoing study in which we are trying to see the cognitive deficits to that of the changes in SAI and ICF. So various patients with and without RBD Parkinsonian disorders. So that also we have seen specific changes in SIC and ICF. We are also using in patients with depression undergoing various therapy. One of our PhD students' protocol, we are using Jatamansi as one of the mode of antidepressants. We are using TMS as a measure of the prognostic as well as the investigative mode. We are seeing specific changes. It's again ongoing study. Only few patients have been recruited. We are seeing the changes in various intracortical circuits in terms of SIC and ICF, and also in silent period. So to summarize, TMS has given us a very important physiological tool to understand the neuronal circuits. We can combine it with various other modes, like EEG and MEG, and other imaging modes. Various other non-invasive brain stimulation techniques can be combined to achieve optimal benefits. That's the whole idea, to understand the brain circuits and to use those knowledge to alter or bring back or modulate those circuits to come back to the normalcy. And this is very exciting area to understand as well as use as a therapeutic modality. Because we won't get both these aspects, investigation as well as treatment, in one go, but TMS provides such opportunity, so we can use it optimally. I would like to thank my postdoctoral supervisor, Professor Chen from Toronto, and also current lab headed by Professor Satyaprabha in our Department of Neurophysiology. Also like to thank all the funding agencies and patients and patients. I'll be happy to take any questions if is there from the online or the on-site attendees. Thank you. Thanks again, Department of Physiology, AIIMS, especially motivation to do these workshops. Thank you.
Any questions from anyone, online or offline?
I think Dr. Kaviraja will be pleased to answer.
Dr. Abhinav, you had some question. You can ask him. He is the expert.
Sir, I had a question that how much is the risk of epileptic foci with MEP in MEP generation with RTMS as compared to the conventional electrical stimulation that we do?
Yeah, very good question, Ajay. I haven't gone into that side effects or the safety profile of TMS. So one of the screening, one of the contraindications that we say is any metallic implants in the head and neck area, mainly the ferromagnetic substances. Nowadays they are using non-magnetic substances because they know this kind of investigation, even in MRI and other TMS related things, those are all the contraindications. So they use non-ferromagnetic substances for those things. But these are any metallic implants in the head and neck area is one of the contraindications. The other contraindication in epilepsy. Of course, we have also done a study in which we have used RTMS. This is done in Toronto. Patients will be admitted in epilepsy monitoring unit to exactly pinpoint where is the epileptic focus. So some patients, even after 1 week of admission, they won't develop any seizures. So then we try to induce seizures using RTMS, using theta burst stimulation. We try to induce, but of course, in our 8 subjects were recruited like that, we were not able to induce seizures. So in that way, it is safety. But there are few studies in which RTMS in epilepsy prone or patients having history of epilepsy, even family history of epilepsy, sometimes it's a contraindication. The whole idea is if the epileptogenic focus is in the cortical side, and when we use the magnetic field, especially the RTMS, this repetitive nature would trigger this epileptogenic focus. And there are few reports showing RTMS inducing seizures. So that's why it is a contraindication. So we need to do thorough history or the family history of epilepsy. Sometimes it is family run, some genetic disorders of epilepsy are there. So that's again, then there will be a contraindication. Otherwise, it's safe when it is done under supervision. A few things we need to, especially when the orientation of the coil, all those things should be taken care. It should not be given to any patients with any disorders. But we have been using TMS for last 20 years with not much side effects. One of the other common side effects is the pain. So when we give it on the scalp muscle, there will be scalp contraction that causes the pain. So, but this pain would go after taking rest or plain painkillers. It would go with a few hours, even few minutes to hours. So it's not a, but we need to explain that to the subject, because some patients or subjects might develop pain because it's mainly because of the scalp contraction. It's nothing to do with any changes in the brain circuit level. Any other questions? Or?
Sir, what is transient neural oscillations, and can it be used as a biomarker for effectiveness of TMS?
You're asking about transcranial ultrasound?
No, sir. Transient neural oscillations.
So the neural oscillations
used, or can it be used as a biomarker?
Yes, those kind of studies. For that, we need to have a TMS EEG setup. TMS, when it is given, usually if it is we don't have the EEG compatible setup with that of the TMS, there will be a large amount of stimulus artifacts, and we won't be able to get any recording for around 100 to 200 milliseconds. So we need to have a TMS compatible machines to get that. If we have that, then these oscillations, what we known as TMS induced evoked or TMS induced EEG changes can be studied, and that again oscillations, say for example the person is having specific oscillations, say beta oscillations, so that can be targeted and that can be studied to change the oscillations to gamma or theta depending on the frequencies. There are studies going on in the TMS EEG labs in this. We can do that, oscillation induced changes. Hope I am clear.
Yes, thank you.
It can be used as biomarker, but for able to establish bio. I don't I think not much work done oscillation. Trying to actually correlate with, you have to validate your other methods before it can be the diagnostic approach.
So like biomarker see the effectiveness immediately rather than waiting for long terms, let's say 6 months or more.
Like in patients in case, I mean, TMS biomarker means what? You can take a blood sample and you can, you can do estimations of different neurotransmitters or different. Or TMS can be associated with fMRI or other techniques like Dr. Kaviraja was saying, with EEG, with MEG or fMRI. Even FNRIs can be used. And therefore, after giving TMS, you can have these sessions of before or after all the trials, you can have that associated with different techniques. And therefore, you know that what is going on into the brain, and you get some idea that what changes has been induced by TMS.
Okay.
Any other queries from online, please? If any queries as of now, we have Dr. Kaviraja with us. So, anyone? Any of the undergraduate students?
I will mention about silent period.
Can you speak? I think.
Can you hear me? Dr. Kaviraja, this is a wonderful presentation you had, and I mean it's wonderful seeing how we move from the electrical age of mobiles and where things are going into thoughts to the field of magnetism, where we are using it in applied fields, and great therapeutic uses you had explained in your. There were a few questions I had. One, both ma'am and you had explained about the silent period, and that refractory period seems to be an important concept which was mentioned, but probably I couldn't understand it in detail. That is the first question. Second, you've been doing this in patients of depression, Parkinsonism, epilepsy, as Dr. Abhinav also asked. So, how much time have you seen that the patient has recovered? I mean, what is the prognosis of a paralytic patient? Has he improved? Can it be done in a normal patient? Like, for example, if you're an RTMS machine here, can I be a volunteer to kind of get into the machine? Will a headache be caused? You were mentioning. You can answer these questions because this is a new field of neuroplasticity also, which is really wonderful point of research, as Gaurav was also asking, because it can be correlated with your deep brain stimulation as well as biomarkers of neurotransmitter measurements in memory. So, what is silent period? One. Second, can it be done in a normal patient? What are the prognosis of your patients which you have been treating of various diseases?
Thank you for that question as well as compliments. So the first aspect, the silent period, I can again show you that slide. So silent period is the time in which there is electrical silence from the muscles. So basically what happens when you stimulate, there will be a motor evoked potential will be generated like this. So this is the when you stimulate here, there will be generation of motor evoked potential, and then there will be again the electrical activity. Usually, after MEP, it will go into that silent mode. But what happens if the person is already contracting? There is a background EMG, what we call. This is the background EMG. The person is already contracting. It's a voluntary contraction he is doing. Then that's one of the ways in which, if you are not getting the MEP, this is one of the ways in which we activate the corticospinal tract. The whole motor circuits get activated when the person is actively contracting. Then it's easier to generate an MEP. So this is when we are not getting MEP, we'll ask the subject to voluntarily contract. But in this silent period, we specifically ask him to maintain 30% of his maximum voluntary contraction. We first measure maximum voluntary contraction, and we ask them to do 1/3. We can use hand grip dynamometer, or sometimes we use a ball to ask them to squeeze at around 1/3 of their maximum. And during that, you can see here the background EMG is there. Then following stimulus artifact and that latency, there's a time in which it activates the motor cortex and it will come to the corticospinal tract and activate the muscle here. We get the motor evoked potential. And following the motor evoked potential, there is a pause in the electrical activity. Again, it won't be, sometimes it won't be absolute pause. There is slight electrical activity will be there depending on the neighboring muscles or other things. But there will be a slight reduction in the electrical activity. Even though the person is actively contracting, there is, you can see reduction. Again, depending on the lab, we need to standardize this. Usually we say when it comes back to the original state, from there, again the activity when it starts. So that is taken as the silent period, and the value is around 120, the range of around plus or minus 10 milliseconds. So that's the normal range. So what is the reason for this? These various circuits in the spinal level as well as in the cortical level. There will be once a response is given, as you have mentioned, the refractoriness will be there for the pyramidal neurons, and this refractoriness because of the various inhibitory neuronal circuits both at the cortical level as well as in the spinal level, they contribute to this. And they have specifically done studies by giving GABA B agonists and antagonists. Also, they have tried with GABA A agonists and antagonists, and it is getting affected by GABA B agonists. It gets increased by agonists and decreased by antagonists. So they know it is mediated by GABA B receptors. So now there is some spinal component is there, some cortical component is there. So if you are interested, you can explore all those things. But this can be used as a measure of one of the inhibitory circuits within the cortical as well as the spinal level. And we also done studies using this silent period as a measure in patients undergoing yoga therapy. In yoga, what happens? We say the prefrontal cortical inhibition is improved. So lack of inhibition is the response for all these issues, problems, and that can be affected by improved by yoga. Yoga, they say pratyahar, or they get maximal inhibition for these worldly effects, right? That's not just by doing asanas, pranayamas, but maintaining that yogic lifestyles. Yama niyama is also very important. That will increase the inhibitory circuits. Various studies from our institute and also various other labs have also shown this. So silent period is increased in these yogic practitioners. That's one of the classical findings we have seen, and that's been reported also. So that's about the silent period. Then your question on various disorders. Yes, we've been using it. This is not given as the first mode of therapy. Usually patients with the depression, say, they'll get their antidepressants as their first mode, SSRIs, selective certain reuptake inhibitors, or other drugs, SNRIs are usually given depending on the patient condition. And when they are not responding to one or the other groups of antidepressants, then the RTMS or yoga in our setup, we also have integrative medicine. So we give different options, yoga, RTMS as the additional mode, add-on therapies for those patients. And even if they are not responding well, then the ECT will be given as the next mode of therapy. And of course, DBS would be there as the last mode in refractory depression. So medications, these the kinds of stimulation or yoga or other Ayurveda or other therapies, added therapies or the complementary therapies, then ECT and then the DBS. This is how in depression cases, and similar kind of things will also given in Parkinsonian or schizophrenia. First medical therapy, then these stimulation therapies, then of course deep the invasive stimulation therapies are given as a mode of treatment. Am I clear?
Yes, thank you. Thank you for the very lucid, detailed explanation. Yeah, can a healthy individual get into this machine with any side effects? The third question, the last question.
You are muted, I think.
Can a healthy person, sir? Thank you for the lucid explanation, detailed explanation, especially on yoga, because yes, we know that GABA calms the person, thus increases the silent period, and also the various effects that you mentioned on the depression, where you have the drugs plus the RTMS and then the DBS. But can you please tell me if a person, if he has the courage, a normal person, to get into the machine, he won't get a headache or something? Can a normal person get into this machine?
Yeah. So in the later on workshop, I think you should be volunteer and you should undergo. Especially for single and the paired pulse, even there won't be much headache also. The headache will be there for repetitive transcranial magnetic stimulation. For single and the paired pulse, which is actually the stimulation time is in microseconds, 100 microseconds or so. It's very brief. So when you stimulate, of course, you will get a twitch in your muscle of interest. Other than that, you won't feel anything. And yes, all of you should undergo single or paired pulse in today's workshop if possible. Then you will understand. And we have done lots of healthy volunteer studies. I myself was volunteer. That's how you give confidence to your students or your observers to undergo these kind of investigations, right? It's perfectly safe, and we've been using, as I told, for 20 plus years. In terms of RTMS, yes, we need to get ethical clearance, and sometimes they question when you are using RTMS, it might change their brain plasticity and might affect the healthy persons. But of course, these changes also, it's transient. It's for few minutes to hours, and as long as you use all the safety protocols and done under supervision, using some cognitive tasks, whether RTMS changes the cognitive profile. One of the study has been recently published in IGPP also. So those kind of studies in healthy volunteers we have done. So it's completely safe as long as you follow all the safety protocols and done under supervision.
Thank you so much.
Yeah, thank Dr. Kaviraja, you made my job easy. Physically, it was supposed to answer to quality. So don't worry, Dr. Varun. Actually, I was the first one when we got our first. I was the first, subject. So before I could ask my attendant or my students to go take RTMS, I did actually sat on the chair and
it first time. So that once I have taken it, I know how it feels, and then I can ask and others to actually take it. So don't worry, nothing will happen. You'll be safe. And you'll have so all my students who are working in AIIMS, they have already taken this TM. So like he's saying, single pulse actually it's just recording of motor potential. So that's what I was saying, that when it started, it was basically for recording motor. But for RTMS, definitely you have to have ethical skills. But then in literature, there are studies where people RTMS see the cognitive performances, motor performances, just to have some basic idea that how the physiology must be working, how the physiology must be getting altered. So there are studies, but for single pulse, it's very, and actually generally we don't get any. I didn't get any headache. So I had number of such single pulse recordings because we take motor potential and cortical silence. In between, if you're taking single pulse, unless you or your family have some history of epilepsy, like he was saying, that contraindicated. But otherwise, it's quite safe. Thank you, Dr. Kaviraja. I think we can take a small break. Thank you all the explanation and answering all the questions. Okay, just minute. I think 1 minute, Dr. Ajay. We have with us Dr. Ajay. He has also one question. I think that should be the last question.
Good morning, sir. Sir, extreme gratitude for the wonderful teaching. Sir, I'm from the psychiatric fraternity, and sir, I wanted to ask one thing. So given the instant therapeutic result it offers to the people who are suicidal, depression tendencies, and the people who are having chronic fibromyalgia, sir, I wanted to know that some patients, psychiatric patients especially, they develop addicted tendencies towards this RTMS. But sir, giving the chronicity of the procedures they required, because also the frequent will face economic and financial crunches also. So sir, I wanted to know that, like, is it in the long run weighing the benefits and the pros and cons of the procedure, like, sir, is it documented that this is really addictive, and if it is addictive in the chronic long run, have a side effect if it is done for the long run patient? And also, sir, one thing for the academic purpose, like, is this also working on the principle of vagal nerve stimulation? Because sir, like yoga and magnetic stimulation, I also wanted to know that, like deep breathing, is this RTMS somehow related to vagal nerve stimulation, so that parasympathetic system and relaxation are working hand in hand with this? Thank you.
Thank you for that wonderful question. So we are working on some of these aspects, especially in patients with addiction. We are trying to explore which circuits are getting affected in these people with addiction. And have you asked on the addictive of RTMS per se? No, right? With some patients,
especially the who are having depression, severe depression, and patient with chronic fibromyalgia, in which is refractory to drugs and other therapies. So giving them RTMS, it brings instant therapeutic result. So sir, in those patients, they have tendency to become addicted, and they ask for more frequency of sessions. So sir, in that case, in long run, how do we proceed?
Yeah, that's possibility. Of course, what is the role of TMS as an investigative mode to understand the addictive things in these patients? We need to explore. It's a good question. We need to explore that. And also, I have seen in one of my PhD thesis case, I worked in patients with depression and undergoing different modes of antidepressant therapy, and one mode being RTMS. So they tend to come to hospital for treatment, right? This RTMS is given as a therapy for 2 weeks, standard therapy. Then if required, as per the psychiatrist's opinion, they will undergo booster doses, just like we receive booster doses for Covishield or Covaxin. Like that, RTMS is given as a booster dose once in a month or 2 months, something like that. But they tend to come back. Maybe we need to explore these patients who are having some kind of addictive things. It's a good thing. We need to explore that. And the second aspect that you have asked is, I missed that part. Can you just repeat that?
Sir, I just asked about about that if vagal nerve stimulation and
Vagal nerve,
this
vagal nerve,
RTMS transmit.
Yeah, we are also working on that aspect. There are two ways of looking into it. One is whether RTMS per se will affect the vagal activity. We have done that kind of studies. Means we also have this HRV. HRV is an indicator of the neurocardiac regulation, heart rate variability measures. So it has various fluctuations, low frequency, high frequency, and high frequency is generally considered as a vagal marker. So we have seen changes in the vagal activity following RTMS therapy in patients with depression. That's seen. We are also trying to use the vagal nerve. Nowadays, we are getting non-invasive vagal nerve stimulation. This transcutaneous auricular vagal nerve stimulation. We can stimulate the auricle of the external ear. There are specific stimulators are there. We put the anode and the cathode, and that activates the auricular branch of vagus, and that in turn activates the vagus. We also have animal models for that in our department. Studies being done using TAVNS as a therapy in animal models of depression. We are also trying to do the clinical aspects, the translational aspects of that in patients with major depression. These studies being done because the polyvagal theory of depression says that the vagal activity is very important in depression. So whole idea is there is decreased activity of vagus in depression, and that we can enhance it with, of course, non-invasive is the preferred mode, or else there are studies even with the invasive vagal nerve stimulation. That is neurosurgically a stimulator is kept in the vagus and it activates the afferent vagal nerves, not the efferent to the heart. The specific stimulation parameters, we can specifically target the afferent fibers, not the efferent, because efferent fibers will stop, the cardiac arrest would be there. So there are specific parameters we need to study. But of course, using TAVNS, the transcutaneous auricular vagal nerve stimulation, is a safe thing, and we are doing studies in that. And of course, there are other labs also working on this TAVNS model. So this is an interesting aspect of targeting the vagus in various subjects, be it epilepsy. Also, the studies are there in depression. In other models are also there are studies using the VNS.
Thank you, Dr. Kaviraja.
Thank you, madam.
Now we'll take a short break. So it's 11 o'clock by my watch, and we'll take a 15-minute break, and we'll come back around 9:50, 11, 50. Okay, see you in 11:50. Okay, please be online. See you in 11:50. Just you can have a break for 10 minutes. Please don't log out. Just keep logging in, and we'll come back at 11. And those who have not shared their DMC state council registration numbers, Delhi or state council registration number, please do the same on chat. Please share your registration number, that is required for giving you the credit points. Thank you.
स्टॉप कर देता बीच में पूरे तो क्लिप बन जाएगी। देख लो जैसे कंफर्टेबल 15 मिनट्स के लिए ये चलते रहेंगे, ड्रॉप कर देना उसमें से वीडियो स्टॉप हो जाता है ना, वैसे कर लेना कर सकते हैं।
I'm from NIMHANS. Actually, no, I came to AIIMS last time in 2009. तो उसके बाद से अब ना मुझे कुछ याद ही नहीं था कहाँ पे आया। सब पार्किंग का भी चेंज हो गया, तो I went
अनजॉन अभी मैंने कैमरा ऑफ कर दिया है, व्यू कुछ नहीं जाएगा।
सामने आकर के पार्क की तरफ मुड़ते हो ना, यहीं पे खड़े हो जाओ। मैं आ रहा हूँ 2 साल में। ये लाल गाड़ी और ये खड़ी यहाँ पर दिख रही है क्या आपको? हाँ हाँ, तो बस यहाँ पे पेड़ के नीचे खड़े हो जाओ। हाँ, तो इससे थोड़ा सा लेफ्ट साइड में राइट साइड में लाइब्रेरी है और लेफ्ट साइड में है हाँ रेडिएशन लाइब्रेरी। हाँ, इसका नहीं किसके पास है? अजय तुम्हारे पास है? अब मुझे फोन पकड़ना चाहिए। EHS नंबर कहाँ जा रहे हो? बना ली मेरी आपके रीना मैम देखो ना इधर जब टीवी करा दे अच्छी तरह अभी ऐसे नहीं आ रही चलाने वाली तुम तो वहाँ जा रहे थे ना नहीं होता। अरे वो बहुत दूर हो जाएगा 4 दिन में। अब किस टाइम से हाँ हाँ 4 दिन में कहाँ जाओगे? अब किस टाइम से होगा? सही आ रही है आपकी सिग्नल। अब किस टाइम से होगा? तब तो वहाँ पे आई कार्ड से मिल जाएगा। एडमिट करो तुम जो किया पता नहीं तुम यहाँ चाहिए मैंने थोड़ा क्या बोल रहे हो? मैं कह रहा हूँ आई कार्ड से टोकन मिल जाएगा। कैंसर वाला ये सामने है ना, न्यूरो वाला पता है इसके सामने लेफ्ट साइड में लाल बिल्डिंग तो अपनी लाल बिल्डिंग को है ना इसके घर में जाते हैं, इसके लेफ्ट साइड में जो मेन लगी रहती है वो
आपके पास संडे तक का टाइम बना लो, 2 दिन में मैं भी
तब आई कार्ड से खत्म हो जाएगा और उसके बाद ओपनिंग कार्ड आई कार्ड
मैं लेके जाऊंगी।
सेटिस्फाई आने चाहिए, सेटिस्फाई इन द सेंस कि आपके लोन है और पर आपको कार्ड में से ले लो, तो आप 6-7 हज़ार रुपये लेकर कार्ड बनवाने के लिए देते हैं।
मिनी कार्ड में मिनी आप डाल देंगे
उनको ये होना चाहिए कि हाँ ये लोन जैसे कि कौन है वो आपके
मेरे भैया है, हाँ उनके फ्रेंड है,
उनके फ्रेंड का मतलब भाई तो भाई है वो तुम्हारा भाई है वो तुम्हारा उनको बोलता है कि मेरे भाई है
2 दिन का है ना,
कजन
उनको दिखाना है, फिर वो जब नंबर देंगे
नंबर दे देंगे
जीबी
उसी दिन का वो कार्ड बनाएंगे
स्क्रीनशॉट
उसी दिन
टाइम
देखो
मंडे
संडे को मंडे को दे पास कुछ नहीं करना, मैं बताता हूँ उसमें क्या होता है IRCH में।
अरे अब कब शुरू होगा भाई?
सुबह 9 बजे सुबह मैम एग्जैक्ट 9 बजे IRCH की बिल्डिंग में अंदर जाओ, फिर उसी सीधे लास्ट में जाके
राइट साइड में टोकन मिलता है।
हाँ राइट में जाओ, शायद 52 नंबर है, उस कमरे में टोकन मिलेगा। भाई के साथ
को लेना है कि जो आएंगे वो
आपको लेना पड़ेगा।
हाँ लोन को थोड़ी मिलता है,
ठीक है,
सिर्फ स्टाफ को मिलता है।
आप वहाँ जाओगे तो
तभी तो कह रहा हूँ
आपको
नहीं हो ना, आज तो मैं भी जा रही हूँ।
आपको अपने आई कार्ड का फोटोकॉपी और ESS नंबर से लिख के वहाँ मेंशन कराना होगा। वो एक फॉर्म देगा, उसमें पेशेंट की डिटेल फिल करके और वहाँ जाके आगे जो स्क्रीनिंग होती है ना वहाँ ही दे जाओ, सब जाके तो तुरंत तुरंत दे दो।
सुबह 9 बजे बहुत बोल रहे हो,
9 बजे अरे आप कितने 11:50 को शुरू हो गया? अजय 11:50 को शुरू होगा, 11:50 को शुरू होगा।
ये देखो ये बोल रहा है
11:50 का नहीं है, अच्छा 15 है ना।
हाँ तो बस करने वाला है ये इस टाइम पे सारे ना, वैसे आप जाते हैं हमारे मिर्ची पूरा, लेकिन अभी इस टाइम पे ऐसी डॉक्टर सब जाता है,
बाद में देख लेंगे।
अभी डॉक्टर सब जाता है, गई ना वहाँ पे बर्फ की बर्फ अभी गई है संडे को। हाँ तो अभी तो कश्मीर में वहाँ बोल रहा हूँ, कश्मीर में कहीं गई आसपास वहाँ पे बर्फ क्या अभी सैटरडे से
अरे नहीं अभी रोहतांग में भी बर्फ मिलेगी, बर्फ मिलेगी।
हाँ नहीं रोहतांग आप जाएंगे तो वहाँ तो
अभी मनाली का टेम्परेचर पता कितना है?
मनाली में लेकिन बर्फ नहीं है,
मनाली में नहीं है 50-60, लेकिन ले रोहतांग आगे जाएंगे तो वहाँ बर्फ मिलेगी।
और वहाँ तीर्थन वैली है ना, वहाँ भी थोड़ा बर्फ है। और वो तुम्हारे फ्रेंड है उसकी वाइफ चांद,
उनका आपके साथ डिसाइड नहीं, मैं जाऊँगा
नहीं कौन राइट का
मैं वाला डिसाइड है।
चले वो कर ले क्या स्टार्ट।
हाँ लेकिन
अजय प्लीज जाओ, मैं आपको स्क्रीनशॉट शेयर करो।
हाँ हाँ शेयर करो, मैं PPT खोल लो अपनी। आपको सुनाई देना चाहिए। करो ये मेरे लैपटॉप का है, मेरे लैपटॉप में और क्या सारी
मैं बंद करूँगा, मेरे इसमें क्या करूँ, म्यूट करूँ? आपके बंद आएगा ये ऑन है, इसे बंद कर दो।
किसी के फोन का माइक
कौन नहीं ऑन कर रखा है?
ऑन करो.
Hello.
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 इसका माइक ऑन है, वो हेडफोन लगाना पड़ेगा. स्पीकर ऑन है ना, या तो स्पीकर ऑफ कर दो या फिर हेडफोन.
Am I audible?
Am I audible? Am I audible? स्पीकर बंद कर.
Hello.
ये कनेक्ट करना है, अपना स्पीकर ऑन करना.
Okay, good morning everyone. Okay. Good morning everyone. Welcome back.
Session now.
In this session now, having heard about something about TMS, its principle and its various applications, now we'll have a demonstration.
We'll have some videos
along with PowerPoint presentation to show you how the TMS is done and what all things needs to be done. If a patient has come, how to begin with. Okay, so my students and resource persons, they are experts in TMS. They have been doing this day, night and day out for patients. So I'll request Dr. Reena, Dr. Deeksha and Dr. Shweta to take over. Dr. Reena, I think she'll be joining. She is a research associate who is working in our lab, and she's been working on PD patients, and she'll start with she'll give introduction to the TMS setup, and then we'll move on to that how the patients are to be prepared and what precautions needs to be taken. So over to Dr. Reena.
Thank you, ma'am. As till now, ample of information shared by Professor Suman Jain, Professor KP Kochhar ma'am, and Dr. Kaviraja Udupa on the basics of RTMS, machine neuromodulation, cortical excitability. Now I'm going to explain the practical approach of RTMS. So first of all, a brief introduction to RTMS equipment or machine. So this is an advanced machine with both diagnostic and therapeutic approaches. So the machine available in markets are only for the therapeutic purpose. So it includes the 4 units. So first is the stimulation unit or main unit, which consists of control circuitry and capacitor and used to give the stimulation. And other units as well as our coil are attached to this main unit only. So if you want to increase the intensity, we need a high voltage capacitor. So second is the expansion unit, which allows the paired pulse stimulation. And due to prolonged TMS machine use, which with high intensity and frequency could generate the heat, which may cause damage to the machine. To overcome this issue, an additional unit, which is the third unit, is inbuilt in the system, which is the cooling unit, which regulates the temperature. So it is very important unit. There are different methods of cooling like fan. Some companies use liquid coolant, but due to which coils become heavy. Some other company use fan which generates so much of noise. So here in our RTMS machine in our lab, air cooling is used to avoid such artifacts. For therapeutic purposes, we generally need maximal stimulus amplitude with high frequency like theta pulse stimulation or repetitive stimulation. So we need extra power supply unit which is intended to joint with the main unit. So after these four units, and the next is the stimulating coil for the stimulation, which I am going to explain in my further slides. It is also attached to the main unit. Next is a laptop with inbuilt software. Neuro MSD in our lab is needed for the data acquisition. An air conditioning room with dental chair for patients and other facilities for patients are also available. And so these are the main requirement for RTMS setup. So now you can see the whole setup of RTMS machine or workstation in our lab, and this is the convenient system on the trolley. Includes the high frequency and high intensity stimulators with effective cooling system and the flexible arm for the coil positioning and monitor for the enlarged view of the traces. So this is the main unit, the expansion unit, cooling unit, extra power supply unit. This is a stimulating coil and monitor for the recording or analysis. So now come on to the different types of coils on the basis of shapes, such as the circular coil, figure of 8, butterfly shaped, H coil, etc. Are used for the stimulation. In our lab, we used angulated figure of 8 coil for brain stimulation, and other circular coil and double cone coil used for the leg area stimulation and spinal cord injury used in our lab. So this is the equipment video. Here I am giving you the idea of how TMS setup in our lab looks like. So here is the complete setup of the TMS machine in our lab. So this is the machine with one is on trolleys. The first is the main unit expansion unit with so much of buttons like train button, pause button, frequency button. So you can use these according to their study. And so there are two knobs also. So upper one is to set the amplitude and lower knob is used to set the stimulation. And here is the on off button also. So when the machine starts, it turns green. The next is the expansion unit. These small buttons indicate the monophasic and biphasic stimulation. And next, third is the cooling unit. This no type button indicates this unit, and it is having silicon coil. And last is the extra power supply unit for maximum up to 50 hertz for theta bus stimulation or repetitive stimulation. After properly setting the whole machine setup, now we come on to the patient preparation. So during the first visit of the patient, firstly we take the informed consent form from the patient, and then a standard screening questionnaires and history about the medication and allergies are to be confirmed before the therapy. We will then explain the whole procedure as well as pros and cons of this therapy, and then we make the patient comfortable on the dental chair. After that, for avoiding any interference during the magnetic stimulation, the metal and any metal item should be removed from the patient as well as therapist also. So patient should ask to wear the earplugs because there's so much of noise generated during the process. After that, we localize the CZ or the vertex by using the convenient 1020 EEG system, which relies on the cranial landmarks like Nasian, Anian, and the preauricular points. And then we locate the brain area of our interest to which we want to stimulate. After restraining, restricting the head movement of the patient, we place the coil on the head. Detailed procedure I will explain in the later video. After placing the coil on head, we fix the electrodes on the appropriate muscle for the recording of the response. This was also demonstrated further. So what are the contraindication with TMS? So we should be careful, like the patient should not have any history of brain injury, trauma, substance abuse, stroke, any brain surgery, or other medical or neurological conditions like seizures. And As such, now report says there is no any adverse side effect of this non-invasive TMS therapy, but some rare side effects like the scalp irritation or discomfort, very rarely seizures were noted, and mild headache could be taken place. So these are the standard screening questionnaires. Pre-treatment and post-treatment therapy are as follows, and all information should be treated confidentially. So this is a back depression inventory questionnaire, WHO quality of life questionnaire. This is the pain questionnaire, is a short McGill pain questionnaire, and the VAS scoring for also for the pain. So these are all are the questionnaires. So now I'm going to explain the brief video of how we prepare the patient in our lab. So we are ready with all the necessary requirements like the sterilium, cotton, measuring tape, markers, stick-ons, and electrodes for the placement. So after the arrival of the patient for the first visit, we are taking informed consent, ask and fill the questionnaire, and explain the whole procedure. We are explaining the whole procedure or taking the consent from the patient. After making the patient comfortable on dental chair, we ask the patient to remove all the metals to avoid any interruption during the magnetic field stimulation. Firstly, we localize the area of interest. We use this measuring tape, some marking stickers and marker to mark the exact cranial. So we place the one end on the tragus and the another end of to the another tragus. Now here the reading is the 32 centimeters. So we mark the midpoint. This is a tragus to tragus. And we mark the midpoint, that is 16 centimeter. Then we measure from nasien. This is the midpoint between the eyebrows, to anion, the projecting part of the occipital bone of the skull. So here the reading is 36 and we mark the midpoint 18. So this intersection of this point is CZ. Now we locate the area of interest like motor cortex. This is the 5 centimeter. So we place the stick-on over it. Now I hand over to Dr. Deeksha for the further demonstration. Thank you.
Good morning to all. Thank you, Dr. Reena, for explaining the basics of TMS equipment and the patient preparation and various type of questionnaire with such a ease. Now I will tell about the motor threshold. I will tell about the various paradigm, maybe single pulse paradigm or paired pulse paradigm in my subsequent slide. So as the motor threshold is basically the most crucial and most important step for both diagnostic as well as therapeutic purposes. Motor threshold is nothing but a minimal stimulation intensity which used to produce a twitch or a motor evoked potential in target area. So it can be seen by a visual inspection method or by the EMG recording. Before explaining these both methods, I want to tell about the importance of the motor threshold. Whether we are assessing, we are using a diagnostic tools or we are using for the therapeutic, the threshold intensity play an important role. Without getting a threshold intensity, it is not possible to diagnose any other parameters like motor evoked potential or say paired pulse paradigm. Or without getting a minimum intensity, we can't stimulate a person to give any intervention. So to give any intervention or as well as a diagnostic tool, we have to measure first motor threshold. In the visual inspection method, when we stimulate the motor cortex, we will see a twitch in the target muscle. If there is any observable twitch, then it will be considered as a response. For EMG recording, electrode should be placed on the target muscle, and then we will see for the MEP, motor evoked potential. motor evoked potential on the screen. If there is any potential if there is any potential which has a amplitude greater than 50 microvolt, then it will be considered as the motor threshold. Then that intensity at which that its response is observed, it will be considered as the motor threshold. So threshold could be measured in resting as well as contracting muscle. Resting motor threshold is a minimum stimulus intensity required to produce a MEP greater than 50 microvolt. It basically measures the membranal excitability, whereas active motor threshold is produced in moderately active or contracting muscle. It is a minimum intensity to produce MEP greater than 100 microvolt. For recording both of these both resting motor threshold and active motor threshold is very much subjective. They can be changed or vary person by person. So it is recommended to take minimum 10 consecutive trials. If at least 5 out of 10 consecutive trial, the motor evoked potential is greater than 50 microvolt or say 100 microvolt, then only it will be considered as the motor threshold. Now I will explain the procedure to record the motor threshold. So first we will choose a minimum intensity. For example, in this case we are choosing a 40% of intensity. Apply a stimulus on the cortex. If you will not get any response, then check for the coil placement, whether it is tangentially placed or not. Angle should be 45 degree. If so, then then check for the whether the center of coil coincide with the motor hotspot or not. If it is okay, then check for the electrode. If all is placed at their position, whether and still we are not getting any response, then increase the stimulus intensity by 5% and check for the another response. If we get any response which is greater than 50 microvolt, then it will be considered as the resting motor threshold. After getting a resting motor threshold, for calculating the active motor threshold, we have to ask patient or subject to voluntarily contract the target muscle 10 to 15% of maximum voluntary contraction. After in a partially contracted muscle, we again give a stimulus and check for the response. If there is a MEP which has amplitude greater than 100 microvolt, then it will be considered as the response or active motor threshold. Before going to motor evoked potential, I will tell the importance of these active motor threshold and the resting motor threshold. So both of these threshold will be used to give the stimulation during interventional part. Like we will for the normal RTMS, we used to give the stimulus at 80% or 90% intensity, or if we want to give a suprathreshold stimulus, then we will use 120% or 110% anyhow the the motor threshold. Coming to the motor evoked potential, it is a resulting muscle response to a TMS pulse, a pulse which should be in sufficient intensity to depolarize a motor neuron. It is recorded from a descending motor pathway or directly from a muscle. As already explained, that the MEP should be greater than 50 microvolt 5 out of 10 consecutive trials. So this is the procedure to record the MEP. As you can see, there is the electrode attached. Our muscle of interest is APB, abductor pollicis brevis. So the electrode is connected to the electrode are attached to the muscle, which are already connected to a preamplifier, and through the preamplifier to a monitor. So, and as you can see, there is a figure of 8 coil which is used to generate the magnetic field. So the figure, as I already explained, that a figure of 8 TMS coil generate the magnetic field. As Dr. Suman and Dr. Kaviraja has already explained the basic principle of transcranial magnetic stimulation, that it is based on the Faraday's law of induction. So it states that if any conductor, in this case brain is considered as brain is a conductor. So if any conductor is placed in a varying magnetic field, then it will induce a flux. So this changing flux will induce a current inside the cortex. once we give this stimulus, so there is a pulse artifact shown on a screen. This pulse artifact is nothing but give an idea that stimulation is given on the scalp. This the electrical current induced in underlying cortex then generate a action potential which travel through UMN and LMN and reaches up to the target muscle. From the action potential from the cortex up to the muscle takes some time, which represent by the latency in this graph. After getting the latency, once the action potential reaches to the muscle, it will contract it will produce a twitch or contraction in the muscle. This contraction then taken up by the electrode and shows and generate and produce a MEP, that is motor evoked potential, in the picture. So these are the this is the basic mechanism and the this is the basic mechanism to generate action potential, the motor evoked potential in the underlying muscle. This is a demonstration video taken from our lab, in which I will show you how we calculate the motor threshold and the MEPs. So as already explained by Dr. Reena, the metal should no metal should be intact from the patient intact in the patient body. Patient should be relaxed and comfortably sitting on the chair. Locate for the target muscle. Clean it with the sterilium. In this case also we are taking the APV as our target muscle. This belt is for the connection of ground electrode. The ground electrode should be attached to a bony prominence. Any bony prominence, we are taking an ulnar. Now feel the muscle belly. The prominent part of muscle or a bulging muscle belly is the target is our target muscle. Attach the silver chloride electrode. One electrode for attaching the reference EMG electrode is attached on the distal interphalangeal joint. This is the ground electrode, which we will connect with the belt. The black one is our active electrode and red one is for the reference electrode. After attaching these electrode, now we will set up the parameters. The neuromep.net software we are using to obtain the data, the TMS, that MEP data and other paradigm data. So once you open the software, there is a screen which will be appear, in which you have to put the name of the patient, their gender, date of birth, and the diagnosis, and what treatment we are giving to them. This is the main screen to record various paradigm. The for recording the MEP or a motor threshold, we will go on the TMS, then select the desired muscle, whether right or left. After setting these parameters, we will place the coil. Dr. Reena has already explained how to locate the CZ. So for abductor pollicis brevis, we will go 5 centimeter lateral to the CZ to stimulate the thumb muscle. A coil has been placed, the figure of 8 coil has been placed over that area. Arms should be relaxed. The coil has a green button. When we give the stimulus, the light will flicker. The flickering of light denotes the stimulation. You can appreciate the twitch after giving a stimulation. This is a visual inspection method. Now for EMG recording, we will see on the screen As we have given the stimulus at 40% intensity, there is no MEP recorded. So we will increase the intensity further by 5% and again try to record the graph. If we didn't get any response at 45 also, so we will again increase the intensity by 5%. At 50, as here you can see, at 50% we got a response. So it is considered, the 50% is considered as the resting motor threshold. Now for getting an active motor threshold, we will ask patient to contract voluntarily a partial contraction of the muscle. MT is recorded from the partially contracted muscle. You can there is a red button which is also used to give the stimulation. As you can see here, at 50% we didn't get any response. Then we will increase intensity further by 5% and stimulate again. So at 55 we got a response which is greater than 100 microvolt in amplitude. So it is considered as the active motor response. This is the exam report from our lab. This is a different patient which we have stimulated right now. This is a different patient from that patient. So here you can see in report we get a stimulus area which is cortex, then stimulation site, latency, amplitude, duration, and area under the curve. At 50% for this patient, at 50% intensity we didn't get any response because as you can see the amplitude is less than 50 microvolt, so we didn't consider it as a response. At 55% we get at 55% we get a response which is the amplitude is greater than 50 microvolt, so it will be considered as the first response or the resting motor threshold. After maintaining a voluntary contraction at 53% of intensity, we get an amplitude of greater than 100 microvolt. So it will be considered as the active motor threshold. These motor threshold, while we are giving the intervention, so in the depression patient or the cerebral palsy patient and some other disease and even in stroke, we used this resting motor threshold intensity, and we will give 100% or 80% of resting motor threshold intensity for giving the intervention, whether it is repetitive transcranial magnetic stimulation, continuous or intermittent. As what I am doing in the spinal cord injury patient, I am using the active motor threshold and 80% of active motor threshold to give the intermittent theta burst stimulation. Now coming to the cortical silent period, so it is the interruption of voluntary muscle contraction of the contralateral motor cortex by TMS. Dr. Suman Jain already explained the physiological basis of this cortical silent period. So it is a interruption of voluntary muscle contraction. As you can see, first we get a MEP, then there is a brief period of silence of about 100 to 200 50 to 100 millisecond before again gaining the motor activity in the muscle. So you can also say it a refractory period. The procedure to record CSP is first find a motor hotspot, then record for the AMT, deliver a TMS pulse contralaterally and record the CSP. So as you can see, the patient should be relaxed. Then we will ask patient to contract maximally, then maintain a 10 to 15% of maximum voluntary contraction in order to record the cortical silent period. Give a stimulation contralaterally to the target muscle. Now you can appreciate a very beautiful twitch. For recording the cortical silent period, we will go on the paradigm which is silent period. Choose for the muscle. give a stimulus at AMT. After getting AMT, here you can appreciate a brief silence after a maximum voluntary after a MEP. This is the silence after the motor activity. This is also another graph from our lab where you can appreciate at 50% of AMT, the silent period in this patient is 183. The silent period is altered in different diseases. In cerebral palsy and spinal cord injury patient, the silent period is increased after the injury. Before going to paired pulse paradigm, do anyone have any queries? You can ask directly or please put it in chat box. So as the name suggests paired pulse, it means there are two pulse, and after giving these two pulse, we will record different paradigms. So two pulse, in these two pulse, one is a conditioning pulse and other one is a test stimulus. So conditioning stimulus is giving, conditioning stimulus could be subthreshold or can be suprathreshold. A subthreshold is, as all know, that subthreshold stimulus can't produce any action potential or a response. So this subthreshold stimulus is given to recruit more and more number of neuron. After the recruitment of more and more number of neuron, a test stimulus which is of suprathreshold intensity is given, so that maximum number of neurons get activated and we will get a desired response. So there are some parameters like short interval intracortical inhibition, facilitation, or long interval intracortical inhibition included in this paired pulse paradigm. For the CK, we use a conditioning stimulus of subthreshold intensity and test stimulus of suprathreshold intensity. Here also subthreshold intensity should be kept at 80% of resting motor threshold, and test stimulus is kept at 120% of that motor threshold. So first we will give a subthreshold conditioning stimulus and followed by a test stimulus in the interval between the 1 to 6 millisecond. In the picture you can see first we will give a conditioning stimulus. So the first graph is a normal single pulse graph and the second one is of the suprathreshold graph, is of the paired pulse paradigm graph. As you can see, first we will give a conditioning stimulus of subthreshold intensity which will recruit more and more number of neuron. After that we will give a test stimulus of suprathreshold intensity. So in the normal MEP recording we will give a stimulus which will produce a MEP. But for recording the paired pulse, first we will give a subthreshold stimulus which is not enough in the intensity, which is not sufficient in the intensity to generate a motor evoked potential, followed by a suprathreshold stimulus. So this conditioning stimulus will produce a inhibitory postsynaptic potential at the corticospinal neurons, which causes the reduction of number of action potential that can be elicited by this suprathreshold stimulus. So you can see because of that inhibitory GABA A neurons, the action potential or MEP has reduced. So this is the basic concept of recording the CK. Now coming to the intracortical facilitation. So intracortical facilitation is same as the procedure is same as the CK. Here we use a subthreshold stimulus and a suprathreshold test stimulus, but the interstimulus interval is 10 to 50 millisecond, which in CK it was 1 to 6 millisecond. The response is different from the CK in this ICF, as we give a subthreshold stimulus, then a suprathreshold stimulus between the gap of 10 to 25 millisecond. there is a facilitation or increased MEP is produced. The reason behind that is when we give a subthreshold and a suprathreshold stimulus, then both excitatory and inhibitory neurons get activated. For say inhibitory are GABA and excitatory are glutamate. But the glutamate is NMDA or AMPA, have NMDA and AMPA receptor. So first the magnesium has to be reduced to get a glutamate inside. That's why it takes some time. So in this facilitation, because we are giving a time period of 10 to 25 millisecond, the glutamate could enter and it dominate over the GABA. So the facilitation is observed. Coming to the long interval intracortical inhibition, in this we give both conditioning and test stimulus. Both are suprathreshold stimulus, and interstimulus interval is 100 to 200 millisecond. So here you can see first suprathreshold stimulus, conditioning stimulus produce a greater peak of MEP. But after 100 to 200 millisecond, we give a second test stimulus, then MEP is reduced. So this is known as the long interval intracortical inhibition. Sorry. This is the procedure to record LISI and C key and the ICF. So first we will record the C key, in which one is for this patient the motor threshold is 60%. So we will take first subthreshold intensity, and test stimulus is suprathreshold intensity, and the interstimulus interval is 3 millisecond. Record for the graph. So here you can see after giving a conditioning stimulus followed by the test stimulus generate some inhibition. For seeing whether it is an inhibition or not, you have to have a single pulse MEP recording. Compare that MEP recording with this amplitude, with LISI amplitude. Here you can see after comparing the amplitude, you can appreciate a inhibition after giving the conditioning and conditioning and test stimulus at a interval of 3 millisecond. For recording the facilitation, choose for the muscle. Then adjust the intensity, subthreshold and suprathreshold intensity. The interstimulus intensity should be in between 10 to 25 millisecond. Now, after giving a stimulation, we will get a graph. This is the muscle. This is nothing but the integrated activity. In this screen, in the upper screen, you can see, you can appreciate a response. Again, we have to compare this response, this MEP amplitude from a single pulse MEP amplitude. Then only you can appreciate the increase in MEP. For recording the LISI, select for the muscle. Then keep both conditioning stimulus and the test stimulus at suprathreshold intensity. Adjust the interstimulus interval. At 100 millisecond. And give a stimulation. Again we are getting an inhibition here, but it can be appreciated after comparing with the MEP amplitude. Now coming to the interhemispheric inhibition, a supra threshold conditioning stimulus. It is a, till now what we are calculating is a intra hemispheric stimulation. Like within same hemisphere we are taking the inhibition and the facilitation, but it is a interhemispheric inhibition. It is solely depend on the callosal fiber. These callosal fiber are the fiber which connect two hemisphere. So the branches from the one hemisphere. So branches from so these are the callosal fiber have the branches. The branches coming from one hemisphere reaches to the another hemisphere. These are the inhibitory branches. Because if we want to get a appreciated response, then the other response should be inhibited. So one hemisphere, when giving a response, send a negative feedback to another hemisphere to suppress their response so that a desired response can come. Here we, for recording the interhemispheric inhibition, we use suprathreshold conditioning stimulus given to contralateral hemisphere 10 millisecond prior to the test stimulus on ipsilateral hemisphere, and MEP is recorded. Both are the suprathreshold stimulus, and the interstimulus interval is 10 millisecond and the 40 millisecond long. You can see in this picture, coil 1 is placed on the targeted hemisphere, and coil 2 is placed on the conditioning hemisphere, and these are the callosal fiber which is inhibitory in nature. So as you can see, the IHI 10, at 10 millisecond, the response produced is intracortical response. After the 40 second, which is IHI 40, the inhibitory response is produced on the another hemisphere. For recording the IHI, first we have to select the muscle, then place the coil and give a simultaneous response, give a simultaneous stimulation. Here you can see the amplitude, which is decreased. At first the amplitude is 500 millivolt, 5 millivolt, which is reduced in second coil and is 3 millivolt. Then again coil 1 saw a 5 millivolt response, whether it is reduced in the coil 2, so it shows a interhemispheric inhibition. Central motor conduction time is nothing but the time taken to reach the stimulation, the action potential from the cortex up to the target muscle. So coil 1 is placed on the cortex, and otherly time is recorded from the spinal stimulation. So it is placed on the spinal cord and then stimulated and calculate for the time. So T1 is the time from the cortex up to the target muscle, and T2 is the time from the spinal stimulation, spinal cord, up to the target muscle. For getting the central motor conduction time, subtract the T1 subtract the T1 from the T2, and you will get the central motor conduction time. For getting a conduction velocity, the distance divided by the time. This is the procedure to calculate the central motor conduction time. Here you can see a stimulation is given at 60% of the intensity. And we get a latency of 21.2 millisecond. Again, stimulating from the segment, here we are stimulating from the cortex, now from the spinal cord. So spinal cord, we get a intensity of latency of 13.6 millisecond. So after subtracting the 13 from the 21, we get a approx 8 millisecond, which is the conduction time. Coming to the brain mapping is required. The application of brain mapping is for first for the giving a exact stimulation. Before mapping the brain, we will find a motor hotspot on the exact location we can give a stimulation which could be helpful to stimulate the brain. And the another method for another application of brain mapping is to look for the reorganization of the brain after any injury, whether there is any plasticity or not. So there are two methods of brain mapping. First is manual method and second is neural navigation method. Manual method I will explain in further slide. Neural navigation method is much accurate procedure than the manual method, and it needs MRI images of the patients. This is the manual method, in which first we will locate for the CZ, then we will place the coil one by 1 centimeter, 1 centimeter, then again 1 centimeter, then again 1 centimeter to map all the area in brain. Here you can see this is a cap where we have put some stick-ons. The black one is the CZ. We will place center of coil on the CZ and stimulate. Now check for the MEP response. We are getting a MEP at CZ. Then we displace the coil by 1 centimeter and again try to get response. Here also we are getting a response. We will do so by placing coil 1 by 1 centimeter until we didn't get any response. So it is the last point of that area which correspond to our target muscle. By checking this, we can get an exact area which represent our muscle of interest on the motor cortex. Now I would like to invite Shweta for demonstrating the RTMS motor threshold.
Thank you, Diksha. Good afternoon to all. So now here comes the importance of animal research in the field of magnetic therapy under the title Red TMS and motor threshold determination. So need for animal studies for TMS. Most interesting thing about this research, that is TMS research, is that it follow a top-down approach where human experiments were performed first and then animal studies. So which is mainly to direct the molecular mechanism which is still to be unraveled. So mainly this research is developed for human brain exposure. There is a significant improvement in human patients in different neurological disorders. As in our lab, we are doing effect of this TMS on spinal cord injured rat in PhD research work of Diiksha, and in master's work, the effect of TMS is studied with Parkinson disease rat. So with those studies and data, we can't understand the cellular mechanism of action of these magnetic field stimulation. But in case of animal model, we can dissect out after exact focal delivery of magnetic field, as magnetic field deteriorates only distance from the central point of stimulation and discrete stimulated central point of stimulation. So different brain regions which are surrounded by adjacent cortical or subcortical tissue that also may receive stimulation at lower intensity, but the contribution of those specific area on which the effect of TMS remain ill defined. So after getting this fundamental approach, it is necessary if we successfully manipulate brain stimulation in order to harness the excitability and plasticity that can promote optimal recovery following injury. Like in my PhD work, I am studying the effect of RTMS on cognitive and motor functions in 6-hydroxydopamine rat model of Parkinson's disease, and my colleague Gunjan is doing her PhD work on effect of ITBS on spinal cord injured rats. So these are different rat coils which are commercially available, figure of 8 and the circular coil, and in our lab we are using this circular coil. So the basic protocol which is followed for TMS stimulation, first of all, rat is anesthetized or restrained. In our lab, we basically restrain the rat to avoid the effect of anesthesia. After restraining the rat, localization of the site of stimulation is done. In our lab, we mainly focus on motor cortex area, followed by the placement of coil, and after placement and giving stimulation, then the confirmation of stimulation is done by visualizing the twitch, followed by electrophysiological recording. So this is the circular coil which is placing at motor cortex to stimulate the rats. This is the demonstration. First of all, rat is restrained, then the left hind limb is shaped for electrode placement. These three are the electrode, that is ground, active and reference. This is adhesive gel. Ground, these are the three electrodes which are placed at different positions. This is the circular coil. And this is the machine setup on which we can save our protocol, specified protocol, and by pressing the button we may enable the machine, and by scrolling we may increase our amplitude. So basically with rat we use 12 to 15% amplitude. We stimulate motor cortex area which is 0.4 millimeter mediolaterally present to the bregma, and bregma is estimated 0.9 millimeter anteriorly to the midpoint of the intraoral line. So first of all, midpoint of the intraoral line is determined. Then 0.9 millimeter anteriorly to that point is the bregma. And 0.4 millimeter mediolaterally to that bregma is our motor cortex area which we stimulate. So after stimulating, we get our twitch. And this is the graphical representation of MEP. Then in our lab, we also use magnetic field chamber for magnetic field therapy, and this consists of 4 circular electromagnetic coils, 2 outer coil and 2 inner coil, each with diameter 1 meter, and there is a central platform which is denoted by P on which rat is placed in a specially designed polypropylene boxes. The 2 outer coils consist of 18 tons each, and 2 inner coils consist of 8 tons, and the distance between the outer coils from center is 470 millimeter, whereas the inner coils are 122 millimeter, and all the coils are connected in a series and provide a uniform magnetic field of 17.96 microtesla and 50 hertz at central platform. A regulator is also attached with it, which maintain a constant current of 17.96 Tesla through the coils. And the chamber is adjusted to 17.96 specific microtesla before exposing the rats by using magnetometer. Thank you.
Thank you, Dr. Reena, Dr. Diksha, and Dr. Shweta. We can have questions now. So, what they have shown that we have in the brain stimulation lab in the Department of Physiology and in neurophysiology lab. So, brain stimulation lab we have the setup for working on human subjects and patients, and then in neurophysiology's lab is more dedicated to animal modeling and animal work. But whatever work we are doing on patients to understand the underlying pathophysiology or what is the effect of magnetic stimulation in the patients if we are doing. So we have animal models for various neurological disorders, Parkinson's, Alzheimer's, stroke, and then spinal cord injury. And so we give different protocols of magnetic stimulation. So we can give, as Shweta was showing, we can give whole body exposures also. So we in 2000 we actually started with whole body exposure because that time we didn't have specific rat coils available, and it was so we started with whole body exposure. But now we are able to purchase the
coil, and we have standardized the procedures in rat also, so that we can now specifically stimulate the cortical areas, and therefore we can exactly actually understand that what is happening when we are giving stimulating
and that what is then we can take out the brain or the spinal cord and do all morphological or different type of studies by
any questions, please, any queries?
any queries if you have. Yes, please. Any questions from anyone? Any query? Or it seems everything is clear to everyone? So, in case any of you, I can see there were number of faculty members, residents, and students from different institutes. So, if any one of you is interested in establishing a lab, or you want to have a training in human patients or animal models, you're most welcome to come to AIIMS or even go to NIMHANS. Dr. Kaviraja is an expert. Whichever place is nearer to you. We would like to have you and provide training as a for whatever duration you require, or in case you have TMS system in your institute, then definitely we are open for collaborations and interactions. Questions and interactions is can we have a camera, so that I think another requirement of the organizers were that can we have few cameras on, please, so that we can take a screenshot? Or in case you want to share your experience videos, I think we can do that. If you allow me, I can take few names. Dr. Prabal, are you there? Or maybe Dr. Saroj, Dr. Ajay, I can see few names here. Anyone would like to share their experience or give us suggestions how to improve our videos and presentation. No one? And those who have joined, please share your DMC number or your state council registration number. Many of you have shared, but there are others who have not shared and have joined. I can take the names like Dr. Smriti, Dr. Ajay Nene. Please share your registration numbers. If Dr. Namni, Dr. Swapnil, if they are there, please share your registration numbers. Anybody wants to share your experiences? You can write on chat also in case you have some suggestions or some anything you want to say. You can switch on your audio, you can switch on your camera or write on the chat box. So this time we are doing online, I think, but we would definitely love if next time on any other platform, if all of you can come to AIIMS Delhi and visit our labs. I think that will be real great pleasure to all of us. If no queries or suggestions, then thanks for patient listening. And as you can see, as Dr. Has immense potential. So as a physiologist, you can do a lot using TMS. So it has a very, very recent technique and which is in now news. Everybody is trying to use that. So from a physiologist point of view, can contribute a lot by using learning TMS and can support clinicians and can do a lot of different type of research work and can associate different techniques like Dr. Kaviraja was saying. I mean, you can do yoga also, you can go for TDS and you can associate with this fMRI or EEG and other techniques, and this can be used and therefore has a lot of diagnostic and prognostic value attached to it. So, okay, thank you. Thanks to all of you for attending this workshop. Thank you.